High blood pressure is an important risk factor for stroke. About 75% of patients of acute stroke have high BP, with 50% of those having prior history. In 2/3 of such patients, BP decreases spontaneously in the first week following stroke, while rest remains hypertensive, with an increased risk of an adverse outcome. High BP can lead to cerebral edema, hematoma expansion, or hemorrhagic transformation. Rapid and large reduction in BP can lead to expansion of cerebral infarction or perihematomal ischemia due to reduction of cerebral blood flow. Therefore, it is very important to manage the high blood pressure in right way to avoid further complications. Blood pressure goals in acute ischemic stroke. If thrombolytic therapy is considered, BP should be less than or equal to 185 by 110 mmHg, which should be maintained at or below 180 by 105 mmHg for at least 24 hours after initiation of treatment, for which continuous infusion or multiple agents may be required. Frequent BP monitoring, every 15 minutes for 2 hours initially, every 30 minutes for next 6 hours, followed by hourly for 16 hours from start of thrombolytic therapy is recommended. In patients who are not given thrombolytic therapy, BP should not be treated acutely. The exceptions being extreme hypertension, that is systolic BP more than 220 mmHg or diastolic BP more than 120 mmHg. Acute ischemic coronary disease, heart failure, aortic dissection, hypertensive encephalopathy, or preeclampsia, eclampsia. It is advisable to decrease BP by approximately 15% during the first 24 hours after stroke onset, preferably by intravenous agents. Choice of antihypertensive in acute phase of stroke. There is no single optimal medication to lower the BP. Reversible and titratable intravenous agents like leptilol, nicardipine, clevidipine, hydralazine, and enlaprilat are preferred for BP lowering. Intravenous nitroprusside may be considered in uncontrolled BP or if diastolic BP is more than 140 mmHg. Important adverse effect of nitroprusside, it carries risk of increasing intracranial pressure and affects platelet function. Medications likely to cause a prolonged or precipitous decline in blood pressure, for example, rapid-acting formulations of nifedipine, should be avoided. Antihypertensive agents should be started only after vascular imaging to exclude symptomatic large artery stenosis. As some degree of BP elevation is necessary to maintain cerebral blood flow to ischemic brain regions in patients with extracranial or intracranial large artery stenosis. A gradual reduction in blood pressure over 7 to 14 days after ischemic stroke is indicated. Antihypertensive drugs used in acute phase of stroke. Here in this chart, you can see important antihypertensive drugs used in acute phase of stroke with their doses. Acute spontaneous intracranial hemorrhage. In acute intracranial hemorrhage, elevated BP may be due to stress, pain, increased intracranial pressure, and premorbid acute or persistent elevation in BP, and high systolic BP is associated with greater hematoma expansion, neurological deterioration, death, and dependency. For intracranial hemorrhage patients presenting with systolic BP between 150 mmHg and 220 mmHg and without contraindication to acute BP treatment, acute lowering of systolic BP to 140 mmHg is safe and can be effective for improving functional outcome. For patients with acute ICH who present with systolic BP of more than 220 mmHg, aggressive reduction of BP with a continuous IV infusion of antihypertensive medication and frequent BP monitoring is required. Some useful IV agents for controlling BP include labetalol, nicardipine, enlaprilat, esmolol, nitroglycerin, phenoldopam, and phentolamine. Subarachnoid hemorrhage, BP management goal. In patients of subarachnoid hemorrhage, antihypertensive therapy should not be initiated unless there is severe elevation in BP, and patient's cognitive status may be useful guide in the absence of ICP measurement. An alert patient indicates satisfactory cerebral perfusion pressure and systolic BP. In such patients, BP should be kept below 140 mmHg to decrease the risk of rebleeding. If level of consciousness is grossly impaired, antihypertensive therapy is generally not initiated, as it may be due to a reduced cerebral perfusion pressure, and reducing BP can increase infarct size. In subarachnoid hemorrhage, leptalol, nicardipine and enalapril are preferred for BP control, and vasodilators such as nitroprusside or nitroglycerin are avoided because of their tendency to increase intracranial pressure. Take-home message. In acute ischemic stroke, if thrombolytic therapy is considered, BP should be less than 185 by 110 mmHg and should be maintained at or below 180 by 105 mmHg for at least 24 hours. In patients who are not given thrombolytic therapy, BP should not be treated acutely, exception being extreme hypertension. 15% reduction in BP during first 24 hours is recommended. In intracranial hemorrhage, most guidelines do not recommend lowering BP in initial stages unless systolic BP is more than 220 mmHg. Gradual BP reduction to 140 mmHg is safe. In subarachnoid hemorrhage, goal is to decrease systolic BP less than 160 mmHg in unsecured aneurysmal SAH. In alert patient, keep BP below 140 to reduce risk of rebleeding. If consciousness is impaired grossly, avoid antihypertensive therapy. Medications likely to cause a prolonged or precipitous decline in blood pressure should be avoided in ischemic stroke. Reversible and titratable medicines, preferably IV agents, should be used in acute phase. Chronic oral therapy is indicated after 72 hours if BP is more than 140 by 90 mmHg or more than 130 by 80 mmHg in lacunar stroke, with a target BP of less than 130 by 80 mmHg. This video is just to make aware medical students about lowering BP immediately is not a goal in stroke patient. And lowering BP acutely may sometimes cause deterioration of patient condition, therefore gradual BP control is better. Knowing intravenous drugs used for lowering blood pressure is very important. I hope this video will help students for managing stroke patients. Thanks for watching.